Hello everyone, my name is Jacob Bryan, and this presentation is about the impact of EMS training personnel and how to fix it. So first off, this is me. I said my name is Jacob Bryan. I've been EMT basic since 2021. I was at Wake County for about a year after that. I've been at North State since 2023. Currently an EMT basic preceptor. I have students from Wake Tech, Johnson County Community College, and Durham Tech. So on this slide, we're going to discuss the role of EMS training personnel. EMS training personnel make up EMS instructors, preceptors, field training officers, mentors, or any person who really helps the training of future or new EMS providers. Their primary role is to introduce and prepare students to function independently as EMS providers. ETPs create the first impression of the EMS world to students. They also create a link between class and field education. So first, we have the EMS instructors. EMS instructors give the first impression to students on what the career is like. They're in charge of the didactic or class time training of students. They're also in charge of the skill and lab training in students. And then finally, they prepare students to function as a preceptee during clinicals. The requirement for an instructor, if you want to be an adjunct and you just help a lead instructor, all you need is your basic certification, whether that's ALS or BLS, and then basic knowledge in the field. For instructor level 1, you need an associate's with an instructor methodology class and at least 100 EMS teaching hours. Then for instructor 2, you need a bachelor's with additional EMS teaching hours. So next we have EMS preceptors. They give the first impression to students on how the healthcare field is. They're in charge of training and competency and assessment, skills, and overall confidence in the field. They consist of RNs, EMTs, and paramedics because you have in the hospital and ambulance setting. They are usually a little bit more laid back than your instructors or field training officers. You're just working with them during your regular shift. Usually a requirement for a preceptor is a competency as a provider in assessment and skills, and about a 30-minute video presentation that you'll watch and school-specific presentations. Then finally, you have your EMS field training officers. FTOs give the first impression to an FTEP on how an agency is. They're in charge of making sure an FTEP shows mastery and skills within their scope of practice. They're also in charge of making sure an FTEP is knowledgeable and competent in the agency's operational standards. Requirements for an FTO is they want you to have mastery and competency as a provider and assessment skills and operational standards of the agency. It's also an agency-dependent FTO course depending on where you work at. So for this project, I made a survey. The survey was conducted to grasp former students, current students' perspective on ETPs, along with discussing positive and negative impacts an ETP has on them. The survey group consisted of 911 and medical transport providers, EMT and paramedic students, along with former students. It was an anonymous survey, and there was 4 questions, as you see here. So the first question was asking, do you believe a preceptor, instructor, or FTO's behavior and attitude can have a career-long impact on your outlook on EMS and the patients you pick up, whether that's positive or negatively? The response I got was about 96% of individuals said yes, while 4% said no, so it was overall yes for that question. So the second question was an open-ended question, and it asked ways preceptor, instructors, FTOs has enhanced your education or positively impacted your outlook on the EMS profession. Below are some of the responses. I'm just going to read a couple of them. One of them was that many FTOs adjusted how they taught to my learning style, letting me be more hands-on to make my own mistakes that did not compromise care, of course. Another one, someone said, going through a degree program can confuse a student's direction of assessment when clinicals roll around. Having a preceptor who knows this and can guide you along the line between is priceless. And then finally, they've had preceptors who took the time to walk me through an assessment, and it significantly helped me understand the process better. Then the third question was also a open-ended question. This one asked ways preceptor, instructors, or FTOs have hindered your education or negatively impacted your outlook on the EMS profession. Like the one before, here are some of the responses. I'll read a couple of them. Someone said, on my first clinical shift, my preceptor barely talked to me. Another one said, when teaching, just read out of the book, off the PowerPoint, didn't do anything to engage or explain things at the time, really struggled to retain info at that time. And finally, preceptors that cut a lot of corners, make you feel like things that instructors say is book life and real life have subpar standards, which may reduce a provider's own standard of care. So the last question is another open-ended question and just gave providers a chance to provide any additional information or feedback they have pertaining instructors, preceptors, or FTOs. how they impacted their career learning experience. Below are some of the responses. One person said, preceptors have a great deal of effect on confidence and self-esteem. Loss of confidence can make discouraging remarks become self-fulfilling prophecies. Someone else said that preceptors are poorly trained. Another person stated, asking questions on the way to a call to prepare was always helpful. So this is just a summary of the survey. Providers believe that ETPs can have a lasting impact on a provider, and their outlook on EMS is up to the ETP on whether that will be a positive or negative impact. Providers felt like receiving autonomy from ETPs during clinicals allowed them to build confidence as an independent provider. Providers found that they were successful with ETPs that could adapt to their learning style. Providers found success with ETPs that took additional time between calls outside class to help them. Some ETPs would not do that for students. Providers had ETPs that would only give harsh negative feedback with minimal positive feedback and constructive criticism. Providers had ETPs that would not speak to the student unless during a call and made them feel like they were not wanted on the truck or seen as like an extra chore. Then some ETPs completely disassociate class and clinical education, which can lead to a decreased level of care. So this slide, we're going to be discussing the benefits of ETPs. ETPs all have field experience, even if it's not recent. They also have all been students before, so they know how it is. They're usually lifelong learners of the profession. Having ETPs, it allows you to see all aspects of the EMS and pre-hospital setting and create a connection between the field, clinical, and textbook education. And it's also more understanding than traditional college professors, usually in the field, like I said, or have been in the field before, so they know how it is if you're going through school and working full-time. So this slide, we're going to be discussing the downside with ETPs. ETPs, especially preceptors, can be seen to pass poor behavioral traits and mindsets to students, creating early burnouts. They can also have difficulty with the ability to adapt to a student's specific way of learning, and this is mainly just due to inadequate education. ETPs can have difficulty merging the field, lab, and didactic section of a class. They also may not have the most up-to-date education or knowledge of the state standards or protocols, as they might just know what the agency and school practices at. ETPs also might be burnt out, and they might be doing the training position solely for the money or way out of a traditional field setting. So this slide, we're going to be discussing the preceptor or FTO problem. I do want to say this at first, as I had a very positive experience with almost all of my ETPs, all the preceptors, FTOs, instructors. I do believe that, they might need some reform. It could enhance the education experience for a student. It also does seem that most problems are primarily from preceptors and FTOs. A part of this problem is due to preceptors, requiring minimal training and usually are unaware that they have a student until they come into work and the student is there. Being a preceptor also does not require an application or hiring process. They are selected by the agency, which could be very random in large or busy systems. Preceptors also do not receive additional pay, which does not provide a benefit in the eyes of some of the providers. Preceptors can also be very opinionated and stubborn to think differently, leading to some personality conflicts with preceptees. Preceptors could also be burnt out and cause negative behaviors and mindset to be passed down to the student. Some preceptors just don't want a student. They might see it as an additional chore or more work. And then some preceptors can refuse to adapt to a student's learning style. Now on the side here, this is just the preceptor training. This is all the training that you receive as a preceptor. Each one of these links, it consists of about 45 minutes of narrated presentations all together. Then finally, you take a 130 question test, and then you'll usually have a school-specific PowerPoint discussing the operational standards. And then that's it. That's all they get. They get about 45 minutes of lectured PowerPoints. They take that 30-question quiz, look at that presentation, and then they're in charge of the success of students in the field as a preceptor. So this leads us to our next question: how do we improve it? I believe three main things could help improve the standard of education which a preceptor gives to a student. Those three things would be to evaluate, reward, and to educate. So first, evaluate. So first, we want to improve the evaluation of preceptors. Precepting should be selected by more than just what truck is available or who a supervisor picks for the day. I believe having a detailed evaluation or selection process from a school and agency will help. I also believe increased communication with a clinical coordinator, or at least some Having like yearly meetings with the clinical coordinator, discuss any changes with the program or scope of practice, and ensure preceptors are maintaining the program standards. Could also have something like a personality and learning style test that all preceptors take. This could help better match students with similar ways of thinking. And then maybe implementing like a blackout period. A blackout period could allow for times that preceptors do not receive students when a preceptor feel like they're unable to adequately educate a student at a high standard of education. This could be something like a family emergency, a new partner, PTSD period, or any high level of stress period that might hinder their standard of education which they give to a student. So next, we're going to want to reward them. So you want to be able to reward your preceptors and FTOs adequately. They're the reason people either come or stay at an agency. If an agency or program is benefiting from your work, you should too. This could be done with possibly pay differentials when you're precepting, whether you have a BLS student, an ALS student, or someone you're putting through capstone. Could also give the preceptors newer trucks if they're training. It's also be an incentive for preceptees in an agency as well, because it allows the preceptees to be on a nice truck, feel comfortable. You could also do incentives from the school program, whether that's discounted Con Ed or EMS certification courses, yearly preceptor appreciation dinners or a gift. Also maybe increased pay rate if they do decide to be an adjunct. And then finally, we want to improve the education on the preceptors. So as we discussed before, preceptors are extremely undereducated compared to other ETPs such as FTOs or EMS instructors. The way to improve that is possibly a more in-depth interactive training. Death by PowerPoint is ineffective for most, especially people in the EMS profession. You could possibly have a class day or a video class day for being cleared as a preceptor just to make sure that you're competent. Could also have possibly like a yearly preceptor workshop, whether that's online or in person, just to make sure that the school and the preceptors are all on the same page of what they expect of the student and also what they expect of the preceptor. Could also improve the ways to reach out and become informed from the program. Maybe just a place to put in some comments, any questions, comments, or concerns. Could also educate preceptors in learning styles, personality styles, and working with students with special circumstances. This allows preceptors to better educate a student who might not benefit from certain methods of teaching. And also just talk about creating a better link between classroom, lab, and clinical setting. We'll talk about that a little bit more. Then you also want to ensure preceptors are aware of differences between agency and state program protocols and standards, so they don't tell the student one thing when they're expected to know another thing in class. Now we'll be discussing just some of the key points of education for a preceptor. So one good educational point could be discussing the 5 levels of psychomotor competency. So first one, you have imitation. Can a student do it after watching you do it? Then manipulation. Can they do it themselves but have mistakes or in an untimely manner? It's not all the way there. Then precision. Can do it in a timely manner with no mistakes or independently. Articulation. They perform multiple skills without issues. Then naturalization, where they can do it without thinking, kind of like muscle memory. Then you have the different personality types. You have some people that are introverts, some are extroverts, some are kind of in the middle. For introverts, you want to be understanding. It might take them a little bit to come out of their shell. You want to take time to build rapport with the student as you would a patient. You also want to encourage, but don't force students to become comfortable with the patients, during their clinical time. They are more likely to be quiet during their downtime. You can try to use some of the time for educational purposes or just regular communication. Then you have extroverts. You want to be understanding that they may be very talkative, energetic, and help direct that energy towards strong patient care. Should not have any difficulty talking to patients. Just make sure their assessment is strong. They're more likely to want to talk during their downtime. Just try to make some of that talks educational. Then to piggyback off the personality types, you also have the learning types. Some people are hands-on, some people like visual, some people, strive with verbal learning. Hands-on, they learn best with hands-on, practical learning methods. So something like scenario-based learning. You can also use equipment when training skills. Then visual learners, they learn best when they're able to see the information they're learning. So you could use something like pictures, models, or presentations with images. Then verbal learners, they learn best when they can hear the information and then process it in their head. Do this with video lectures, presentations in class, or just talking to them during downtime, or even doing like tabletop scenarios. Then you have students with special circumstances. So you might have someone with ADHD or ADD. They might require additional and frequent redirection. You might have a patient on the autism spectrum. They might be introverted and have difficulty communicating with patients. Before the shift, you might want to try to obtain triggers, and you want to work with the student on what they need to be successful. Now, if you have a student with a medical condition, some examples would be diabetes, AFib, or asthma. It's important to talk with that student before the shift if that medical condition becomes severe and they have issues with it. And you can just do this to, create a plan if something does happen. Then you also have young adults. You want to understand they might still be working through maturity. Younger learners might not be extremely self-motivated and could use a little extra motivation. The other side of that, you have older students. You want to respect their years of knowledge. They might be older than you. Older learners are usually self-motivated, but they don't want to be treated like a child or a high school student. And to continue on with students with special circumstances, we're going to talk about, a student with depression. They might require additional reassurance or help, especially after a really bad call. If you have this student for a long time, let's say you're doing capstone, you might try to see patterns of severe depression before it is too late. So decreased hygiene, late or missed shifts, or just overall disengagement. Speak to the student on how to help. You also could have anxiety. Something like an MCI, MVC, or psych call might overwhelm the student. They're just kind of having a sensory overload. You want to kind of work with the student to identify triggers of anxiety before the shift. You want to encourage the student when they're leading a call to ensure they're not messing up. So, they're not in their head like, am I doing this right? Am I doing this wrong? Then, you might have some financially unstable students. You might want to understand they might not be able to afford to eat, wash clothes, shower, get new uniforms, have their own transportation. If a student does let you know this, you want to try to provide them with as many resources as possible. Some will not take the handout, some will not let you know, but all you can do as a ETP is try. Then something that's very common in the EMS profession is, someone with PTSD, trauma, or high stress. I think we have the second highest suicide rate compared to the military. You want to understand they might be easily defensive or standoffish. You want to work with the student to identify triggers and make the student feel as comfortable as possible. And then the last kind of slide talking about students with special circumstances. You have students with a lot of experience, whether they've been in the field for a long time or couldn't finish a class. You want to understand they know the basics of what they're learning, might already be competent as an entry-level provider. You want to try to show them new things or, trade secrets to continue to refine and perfect their skills as a provider, and they might not know everything that they think they do. So, just because they say, I know what I'm doing, you still might want to have an eye out on them and, show them new things like we just talked about. And the opposite side of that is you could have students with little to no experience. So these are like brand new EMTs or 0 to 100 paramedics. Common basic knowledge to you, it might be rocket science to them. They might have no idea what you're talking about when you're like, oh yeah, just do this. So, for these students, you don't want to make them feel afraid to ask questions if it's something they should already know. It's rather you answer it now or they go through their whole career without knowing something just because no one took the time to explain it to them. It's better to perfect a struggling student now than to let them become a struggling provider. And then, kind of talking about students with depression or financially unstable, it's your responsibility to be a helping hand to your students by, talking with the student if they're upset, kind of checked out, disengaged, keeping an eye out for their depression red flags, helping the student if they begin to fall behind, see if something is going on, if they'll talk to you about it, just being empathetic of a student's life and problems if they do decide to discuss them with you. If you feel like a student needs support that you cannot provide, you can redirect a student to food banks, suicide hotline, and therapy. You could also just show them to the school support programs. I probably wouldn't recommend just immediately, contacting the clinical coordinator. If they trust you enough to tell you something that's going on and they want your support, they probably don't trust everyone else in the world. So, just keep an eye out for that. So moving off from students with special circumstances, another key point of education we're going to be talking about is the hands-off preceptor approach. And, you can do this by allowing students to do calls as independently as they can or want to. You want to allow students to not be perfect and mess up as long as it's not harmful to the patient. You want to encourage the student to treat the call as if they're the boss and you're just there to support them. You also want to let the patient know you trust the student as a provider. If the student is struggling, you can provide hints to lead them in the right direction without taking over the call as long as it's not harmful to this patient. You do not want to allow you or your partner to take over the call unless it is necessary for patient safety. I will say this is really good for paramedic students because once they get their paramedic, there's a high chance they'll be the highest credentialed provider at any given time on the scene. So you want to make sure they're confident in being able to delegate and make decisions without having to look up at someone and make sure it's okay. Then feedback. You want to provide feedback in a way that a student can benefit and learn from any mistakes during a call. You want to provide positive and negative constructive feedback. Even if there's not many positive things that happen during the call, it's still important to tell the student good things, to help build and instill confidence. You also want the student to be able to ask questions and self-reflect before providing your feedback. You want to give objective, not subjective feedback. Don't allow your political, personal, or emotional views to interject into the feedback if you guys might be on different spectrums on your beliefs or personality types or anything like that. You also want to allow the student to know what you write in the feedback before or after you do it, so because you don't want them to get home, see all this bad things, and be like, I wish they would have talked to me about it before the end of the call, so we could have worked on how to improve that. So going off of feedback, it's also important to give strong constructive criticism to a student. When you're criticizing a student, you want to make sure to state the positives. You also want to provide feedback that they can improve on, tell them how to better their mistake. And you just want to show them multiple methods, not just the way you would do it. There's 99 ways to run a call. Just because the way they would do it isn't the way you would do it doesn't mean it's wrong. You also want to choose an appropriate time to do it. You don't want to do it while the patient's still in the back or while you're giving hospital report. You don't want to embarrass the student. You want to have a time where they're comfortable, you're comfortable, and you guys can kind of talk about how it went. If you've had the student for a long time doing capstone, or if you just had a busy shift, it's also important to maybe point out patterns like, hey, saw every time you did an IV, you didn't take the tourniquet off after you got flash. Just kind of point out that thing so they can see it too. It might be something they're doing subconsciously, and they don't even realize it till you say it. Then you also don't want to hold any grudges against students, whether that's something that happened during a call or personal views. They're under a lot of stress. They might do something they don't mean to do, and as a preceptor, you want to be that helping hand, even if the student is as receptive to it. So just another key point of that. So then conflict as a preceptor. So you want to identify the conflict when the time is right. You want to work with the preceptee before contacting the higher ups, whether that's like your supervisor, their instructor, your clinical coordinator. You want to understand the preceptor. You could be under a lot of stress. Try to identify a solution. Some of it could just be a personality conflict. And, you want to retain a respectful and friendly demeanor when discussing the issues as well. You don't want to just start yelling at them. So communication. Strong communication skills is a necessity for an EMS provider. Competent communication skills might take some time, especially with introverts. Building a strong foundation and progressively trying to improve them is key with students. Some students might be intelligent and be able to perform skills, but might be having some difficulty talking to patients. This might be their first customer service job they've had to do before, or first job in general. You don't know. And you just want to encourage friendliness, active listening, and empathy in students. Build rapport and allow patients to be comfortable discussing complaints, substance abuse, assault, teen pregnancy. Having good communication, just being a nice person can help you a long way for your assessment. If you have a student with some pretty poor communication skills, you can encourage the student to talk to as many people as possible, not just patients, someone at the grocery store, the Starbucks barista, anyone. This just builds confidence to speak to anyone. I encourage students to talk to patients about anything once assessment is done and transport has begun. This creates comfortability in the patient communication, where it's not like you're just a robot talking to another robot. This is an actual person that had a life, and just you're able to do it a lot more fluently. Students are the future. You want to remember the students you train today will be the providers tomorrow. They will be your future coworker, partner, your supervisor, or even the provider that's going to be providing care to your friends and family during an emergent situation. It's up to you to ensure that they will be ready on their own as an EMS provider. These experiences they will have now will shape the type of provider they will become in the future. The bottom line is, treat others like you would have liked to be treated, and remember how you felt during your first clinical or clinicals, and just recognize the gap between you and your student in the field experience. Whether they're an EMT or even a paramedic student, they have these clinicals once a week, a couple times a week, or, EMTs is 4 times and that's it, compared to you where you work, at least multiple times a week. So just recognize that and understand that, they're not going to be competent in everything like you would be. And big thing is optimism is everything. Discussing, outlook on EMS, an optimistic outlook is everything like we just said. The behavior a preceptor has towards EMS can be passed to a student. As an ETP, is your responsibility to project a positive attitude towards EMS. A negative outlook can create early burnout. Here are just some examples of having a positive outlook. When it's talking about EMS, you get to help people every day. It's a great career stepping stone. You get to be a provider, have treatment plans. For patients, you're going to be the light on their darkest day. They need our help, and they're just humans like us. They're not robots. And then for your agency, if it's a large agency, it's resourceful, and chance for a diverse variety of calls. For a small agency, it's more of like a family-like environment, and you get more independence as a provider. Then here are some examples of having a negative outlook on EMS. I say it's just BS calls every day. Only people who aren't smart enough for college do EMS. For patients, they could have just taken themselves or had someone else take them. It's their fault they need EMS because they don't take care of themselves. And, they're faking it. They're not that bad. They just want a bed. And then agency-wise, for a large agency, it's always busy and you're more of a number than a person. Then for a small agency, it's less pay and resources. There's always going to be 2 sides of the coin. It's just important to, have that positive outlook on EMS for a student where they don't know anything. They're going to go into the field and whatever you say is gold to them. So it's important to say good things, have them confident and excited to be able to do this profession. Then the next topic is talking about creating the link. I thought this GIF was pretty funny. So creating the link, first we'll just talk about, all aspects of the training process as an EMS student. The didactic part, in the lab where you master your skills, in the class where you become proficient in EMS material, then doing scenarios where you become confident in EMS patient assessment. Then you have the practical side of it where you do your field clinicals, where you become confident as an EMS provider, and then your hospital clinicals where you become confident in patient interactions and certain skills. Then here are some of the similarities. I'm just going to list some of them. And you got the hospital clinicals will allow you to see the outcome of patients you bring in the pre-hospital setting, whether it's like, you bring a STEMI, you do a clinical, you see what happens in the cath lab. When you bring a trauma, you do a clinical, you see what happens in the trauma bay. Then obviously the knowledge you learn in class is critical to success in the field, whether that's something like a stroke screen or trauma assessment. Skills in lab prepares you to perform skills during practical. Then, the didactic and practical both prepare you to handle difficult calls when you become an independent provider. So here are some of the differences. One part is, class assessments is a lot of verbalizing. When in the field, you're either thinking or doing the action. For thinking, it's, you already think MOI, NOI, scene safety, or the airway being open upon talking. Seeing, you have the skin presentation, track marks or surrounding. So, you'll be thinking and seeing all those things within like the first 5 to 10 seconds. Then doing, obviously you're just going to have the PPE on or do the vitals. Another main difference is the class and lab time is a controlled environment. And the field can be chaotic, critical, and difficult environments. Patients are usually also not as healthy as classmates. Example of that is in the lab, performing an IV on a fellow student on a table who drank plenty of water the day before to ensure their veins would be good, and an instructor nearby if something were to go wrong. Compared to being on the field where you're performing an IV on a 90-year-old patient who hasn't drank water in 2 days with a small rolling vein while you're going emergent at 60 miles per hour on a bumpy road. Looking at the similarity and differences, we'll go back to the link. There are differences between the EMS learning environments, but it's important to look past them and create a strong link between the class, lab, and field time. Class time prepares you with the material to identify and properly treat a patient with a strong assessment. The lab time prepares you to be very competent in skills to allow you to perform them in chaotic and difficult situations. Field clinical time allows you to take the learned material, skills, and assessment to become confident and competent as a provider, even without a lot of initial experience. And then finally, hospital clinical time allows you to take the learned skills from a lab and master them with real patients. Hospital clinicals also allow you to see the outcome of patients you bring to the hospital in the ambulance, such as looking at the ED, the STEMI, stroke, or even a psych patient. And then the desired outcome of the link is to create a provider that is smart and well educated in their scope of practice, competent in skills in any environment, equipped with a strong and competent medical and trauma assessment, empathetic, kind, and understanding of all patients, and confident, ethically, and morally straight. Then how to create the link. In class, inform students that the more you know, the more you can help a patient. Point out critical things to know as a field provider. Give them realistic scenarios. Work on building muscle memory and a methodical approach with skills, whether that's with the ET intubation, IV, BVM, or blood glucose device. Then in the field, you want to point out that real assessments are not as verbalized as ones taught in class. Though it's not verbalized, it is still being thought about in the provider's head. Although seasoned providers might perform assessments that are more oriented to chief complaints, it is important as a new provider to have more of a standard assessment. And you don't want to create a divide between the school and clinical teaching. You'll hear some preceptors or people say, what you learn in school is nothing like how it is in real life. That's just not what we want to have. And then we'll just talk about the goal. So the goal, reform in ETPs could refine the professional development of future EMS providers. It allows for more engaged preceptors, allows for all types of students to learn more effectively and provide a higher standard of care, allows students to build more confidence and competence in class in the clinical setting, provides higher education for preceptors and FTOs. And then just to summarize everything we talked about, ETPs in general already follow a lot of what we talked about. Overall, people have had very positive experience with their ETPs, their instructors, preceptors, FTOs. The problem is the negative interactions have too serious of implications. These negative interactions could lead the right people out of the career for the wrong reasons. Could also lead people away from a good agency due to a bad preceptor. Could destroy the confidence in students. It can create terrible behaviors that providers will carry well into their careers. Can create a divide between what is learned in class and in the field. This could lead the student to believe class material is not useful. It's also seen that most of the issues come from preceptors and FTOs, mainly due to inadequate training. Evaluating, rewarding, and educating preceptors could provide a higher level of teaching. Preceptors and FTOs must be able to adapt and support students based on their personality and learning type. ETPs should work on creating a link between all formats of EMS education, and having a positive outlook on EMS will be beneficial to the instructors along with the students. And thank you for watching. If you have any questions, comments, or concerns, either come talk to me or here's my email right there. I want to say thank you to everyone who participated in the survey. If you would like to provide additional feedback, the link is listed below here, and we had 24 participants in total. Then finally, I did want to add this side note. This project was not made to bash or criticize EMS training personnel, generally or personally. I overall did have a very positive experience with my instructors, preceptors, and field training officers, and anyone else who has helped mentor me during my EMS career. I do believe ETPs have helped me form into the provider I am today. I do believe most can agree with that as well. I just believe that there are some changes that could further improve the education of an EMS student in the field. In the end, that's it. Hope you'll have a quiet rest of your day. Bye.